Hello, everyone. Welcome to our Zoom meeting. Today, we're going to start with different topics. Dr. Aya and her team are going to present these topics. So when you are ready, please go ahead, Dr. Aya.
Hello, everyone. My name is Aya Abdullah, and I'll be the meeting moderator for today. Nice to meet you all. Okay, just 1 second. Right, so our agenda for today would be, the first topic will be talking about diabetes. The presenter would be Dr. Mudathir and Dr. Ziad. Okay, and then the second topic would be student t-test, Google Sheet versus Gemini with Dr. Nabiha. And then how to create a research proposal using Google Gemini Deep Research, and that would be with myself. Yeah, that's all about today. Thank you. So now, if you're ready, the presenter of the first topic should start. Thanks.
Okay, Assalamu alaikum. Hello, everyone. Hello, Dr. Nadir. My name is Ziad Nabil, and I will present the first part of the first topic, which is diabetes mellitus, and my colleague Mudathir will present the second part. So please allow me to share my screen. So please confirm that my screen is visible.
Yes, everything's clear.
Okay. So my presentation will include definition of diabetes, epidemiology, types of diabetes, clinical presentation, diagnosis, complications, and general health recommendation. So diabetes mellitus is defined as a complex metabolic disorder characterized by chronic hyperglycemia due to either insulin deficiency or resistance or both. Mellitus is a Latin word. It means sweet. So diabetes is one of the most common chronic diseases affecting older adults, and its prevalence increases significantly with age. So the highest rates occur in people aged 65 and older. So the contributing factors to this increased prevalence is due to increased insulin resistance with aging. So people, as they age, they deposit fat, and fat increases insulin resistance, and also due to reduced physical activity. So in 2024, about 158.3 million people aged 65 and older had diabetes, and this number is expected to rise by 2045. So age-adjusted prevalence is higher among Black people and Hispanic Americans than white Americans. Black Americans suffer from complications of diabetes at higher rates than white Americans. So in this image shows the prevalence of diabetes based on age groups. So at the bottom, we have different age groups. And at the left side, we have the number of people with diabetes. So we have two colors in the columns, light blue and dark blue. The light blue represents the number of people with diabetes in 2024. So as we can see, older people have increased prevalence compared to younger people. And the dark blue columns is the estimated number of people with diabetes by 2050. So this number is expected to rise even more by 2050. So the types of diabetes are type 1 diabetes, type 2, and other types, which we will go briefly in the next slides. So type 1 diabetes is also known as insulin-dependent diabetes. The pathophysiology is due to autoimmune destruction of pancreatic beta cells. So beta cells in the pancreas secrete insulin. So if those cells get destroyed, there is decreased insulin production, which will lead to hyperglycemia. So this type of diabetes presents in children and young adults, but it can occur in any age. So because this is an autoimmune disease, patients may have other autoimmune diseases such as celiac disease, pernicious anemia, vitiligo, or thyroid diseases. This type of diabetes is not related to obesity. So the second type of diabetes is type 2, which is called non-insulin dependent. This is the most common type of diabetes. The pathophysiology is due to peripheral resistance to insulin. So the body produces insulin, but the body does not respond to the insulin. It classically presents in older adults with obesity. So in this type of diabetes, insulin levels may be normal or high, but later in the disease, the levels can decrease because the pancreas will get exhausted due to chronic overstimulation. So the risk factors for developing type 2 diabetes include obesity, which is the greatest risk factor, and also positive family history, sedentary lifestyle, increasing age, and ethnicity, Asians, Hispanics, and Afro-Americans. So this is a quick comparison between type 1 and type 2 diabetes. The incidence is higher. As we said, type 2 diabetes is the most common. Age of onset in type 1, it occurs at any age, but typically presents in young people and children, and type 2 presents in adults. The cause of type 1, as we said, is an autoimmune beta cell destruction, while type 2, the cause is peripheral resistance to insulin. So people with type 1 diabetes are usually thin, while people with type 2 diabetes are usually obese. So type 1, we have ketosis, which is absent, but may present in type 2 also. The reason is because in type 1, insulin usually inhibits ketone production. So because in type 1 we do not have insulin production, there is increased ketone production. While type 2, there is insulin production, even sometimes there is increased production. So that's why ketosis does not present in type 2. So autoantibodies is present in type 1 diabetes, while it is absent in type 2 diabetes. So endogenous insulin is decreased or absent in type 1 and may be normal, high, or low in type 2. So type 1 diabetes is associated with HLA-DR3 and HLA-DR4, while type 2 diabetes does not have association with HLA. So the other types of diabetes include gestational diabetes. So because pregnant woman placenta produces a hormone called human placental lactogen, this hormone increases insulin resistance. That's why pregnant woman has increased risk for developing gestational diabetes. The other type, which is a rare type, is called MODY, maturity onset diabetes of the young. This is essentially type 2 diabetes, but occurring in young adults. The third type is LADA, which is abbreviation for latent autoimmune diabetes of the adult. This is type 1 diabetes, but occurring in adults more than 30 years. The difference between LADA and the type 1 is that LADA destruction in LADA is slow, while in type 1 diabetes the destruction is faster. So other causes of diabetes include pancreatic diseases such as chronic pancreatitis, hemochromatosis, or pancreatectomy. So all of this can lead to destruction of beta cells, the cells that secrete insulin. There is also endocrinal causes such as Cushing syndrome, glucagonoma, pheochromocytoma, thyrotoxicosis. This all can increase glucose levels, and drugs also can increase glucose levels such as beta agonists, glucocorticoids, and thiazide diuretics. So the clinical presentation for type 1 and type 2 diabetes are similar. Patients may present complaining of polyuria because increased level of glucose stimulate diuresis, and polydipsia as a compensation of diuresis, polyphagia, fatigue, weight loss, blurring of vision. Patients with type 1 diabetes may present with DKA, with abdominal pain, nausea, vomiting, and altered mental status. So diagnostic criteria, either one, the patient has random blood glucose more than 200 milligram per deciliter with symptoms of hyperglycemia, which we just spoke about, polyuria, polydipsia, weight loss, or the patient has two abnormal results with any of the following tests. Number one, fasting blood glucose is more than 126 milligram per deciliter, or 2-hour postprandial glucose level is more than 200 milligram per deciliter following an oral glucose tolerance test, or hemoglobin A1C is more than 6.5%. So complications of diabetes, we have acute complication, and we also have chronic complication. So acute complication include DKA, which occurs in type 1 diabetes. It can also occur in type 2, but is very rare. The second acute complication is HHS, which is hyperglycemic hyperosmolar syndrome. This one occurs in type 2 diabetes. The third complication is hypoglycemia, which can occur in both types in patients which take increased dose of insulin or skip meals or engage in high-intensity exercise. Chronic complication, we have microvascular complication, macrovascular complications, and other complications, which we'll go through in the next slide. So this is a quick comparison between DKA and HHS. So as we said, DKA occurs in type 1 more than type 2. It can occur in type 2, but is very rare. HHS occurs in type 2 diabetes. The precipitants of DKA include infection, trauma, non-compliance with treatment. The same precipitants can cause HHS in type 2 diabetes. So the symptoms of DKA include abdominal pain, nausea, vomiting, small breathing, mental status changes, fruity, acetone, breath, odor. The symptoms of HHS, patient presents with profound dehydration, more prominent than DKA, and mental status changes, also more prominent than DKA. So lab values in DKA include glucose levels more than 250 milligram per deciliter, while in HHS, the glucose levels are even higher, 600 milligram per deciliter. So in DKA, we have high anion gap metabolic acidosis due to accumulation of ketone bodies, while in HHS, we do not have metabolic acidosis, we do not have ketone bodies. So in DKA, we have high urine and serum ketones, and we have normal serum osmolality in DKA, while in HHS, we have high serum osmolality because we have profound dehydration in HHS. So treatment is usually the same. We replace fluid. We give insulin to decrease the glucose level. We frequently monitor electrolytes, especially potassium, so as to prevent hypokalemia. And we also treat the underlying precipitating cause. So chronic complications, as we said, we have microvascular and macrovascular. So microvascular complications include diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. So diabetic retinopathy includes non-proliferative stage and proliferative stages. So in non-proliferative stage, we can see microaneurysm, dot blood hemorrhages, and macular edema, while in proliferative, we see new vascularization, which is new vessel formation. So preventive measures include controlling hyperglycemia, controlling blood pressure, and perform annual eye exam. Diabetic nephropathy starts with glomerular hyperfiltration and then proceeds to microalbuminuria and then to macroproteinuria, and eventually can lead to chronic kidney failure. So preventive measures are the same. We control the glucose level and we also control the blood pressure level. Diabetic neuropathy, so diabetes can affect small nerve cells, large nerve cells, single nerves, multiple nerves, and can also affect autonomic nerves, leading to autonomic neuropathy, which can present with, patient can present with gastroparesis, erectile dysfunction, and neurogenic bladder. So this is an image of diabetic retinopathy. In the left side, we have a non-proliferative diabetic neuropathy. We can see hemorrhages and microaneurysms and hard exudates. In the right side, we have a proliferative diabetic retinopathy. As we can see here, multiple or many new vessel formation. So chronic complications include coronary artery disease, which increases the risk for MI. This is the leading cause of death in patients with diabetes. The second macrovascular complication is cerebrovascular disease, which can result in stroke and TIA. And the third chronic complication is peripheral arterial disease, which can cause claudication, poor wound healing, and there's a risk of limb amputation. Other chronic complications include increased risk for infection, such as diabetic foot, pneumonia, and TB, and dermatologic manifestations, such as necrobiosis lipoidica, diabeticorum, and lipodystrophy. So these are general health recommendations for all patients with diabetes. So first, we start with dietary modification. Patients are advised to decrease intake of saturated fat and added sugar, and they are also advised to exercise regularly, moderate intensity activity, 30 to 60 minutes, 5 times per week at least. And also, all patients aged 40 to 75 years should receive statin therapy regardless of baseline lipid levels. So the doctor can check risk assessment tools to determine if the patient must receive a moderate or a high intensity statin therapy. Other recommendations include blood pressure management. So ideally the blood pressure should be under 130 to 80 millimeter per mercury. So if patient has hypertension and proteinuria, the first line of treatment would be ACE inhibitors or angiotensin receptor blockers. And also patients are advised to screen annually for cardiovascular disease by measuring blood pressure and doing lipid profile, and also to check urine microalbumin and do dilated eye exam and foot examination. Thank you very much.
Thank you very much, Dr. Ziad. Now, Dr. Mudathir will be carrying the second part of the same topic, diabetes.
So, hello, good evening, everyone. Is my screen visible?
Yeah, yes, we can hear you and screen is good.
Okay. So, good evening. I'm Dr. Mudathir Babikir Omer, and I'm going to continue on the same topic that my colleague Dr. Ziad had started, which is diabetes, but I'm going to focus mainly on the clinical, on different aspects of clinical management of type 2 diabetes in older adults. So our main agenda for this session is going to be the management of hyperglycemia. Also, we're going to discuss different types of diabetes medications, also the management of hyperglycemia. And finally, we're going to discuss the comprehensive management of diabetes in different settings. So we'll start with clinical management of hyperglycemia. Older adults with diabetes are heterogeneous groups that includes persons residing independently in communities, in assisted care facilities, or in nursing homes. They can be fit and healthy or frail with many comorbidities and functional disabilities. The appropriate target for glycated hemoglobin or hemoglobin A1C needs to be individualized based on overall health and life expectancy, as well as patient-specific risk for hypoglycemia and the patient's ability to adopt and adhere to specific treatment regimens. In a randomized study, which have been carried out, 10,251 patients involved in this study, with a mean age of 62.2 years, with a median glycated hemoglobin level of 8.1%, were assigned to receive intensive therapy with targeting glycated hemoglobin level below 6%, or the other group received the standard therapy targeting a level of 77%, to 77.9%. Of these patients, 38% were women and 35% had a previous cardiovascular event. The primary outcome was a composite of non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes. The finding of higher mortality in the intensive therapy group led to the discontinuation of intensive therapy after a mean of 3.5 years of follow-up. So, according to this study, the use of intensive therapy to target normal glycated hemoglobin level for 3.5 years resulted in an increased mortality and did not significantly reduce major cardiovascular events. So, in general, intensive care, strict or intensive therapy is not recommended in this group of population, elderly. The targets for hemoglobin A1C in elderly patients, we are going to divide it into like 3 categories. In healthy older adults, hemoglobin A1C goal of less than 7.5% should be considered. And to achieve this goal, fasting and prebrandial glucose levels should be between 140 and 150 milligram per deciliters. The other group is older adults with significant comorbidities. In a medication-treated frail older adults with medical comorbidities, the glycemic goal should be somewhat higher, A1C less than 8%, higher than healthy individuals, and the fasting and prebrandial glucose values must be between 160 and 170 milligram per deciliters. The final category or group is older adults with severe comorbidities or cognitive and functional disabilities. In this group of people, individualized goal for such patients may be even higher. A1C must be higher than the previous two groups, but less than 8.5%, and should include efforts to preserve quality of life and to avoid hypoglycemia and related complications. Now we're going to talk about some limitations of A1C measurements. As we all know that hemoglobin A1C is one of the most commonly used tests in practice, but it has like some few limitations. Number one is the inability to detect hypoglycemia. A1C is a metric mean of glycemia over approximately 3 months. Therefore, it's not useful for detecting hypoglycemia. Further, setting a liberal A1C goal does not ensure protection from hypoglycemia. Also, it has like reduced accuracy in specific settings, like anemia or any other conditions that impact RBC's lifespan, or chronic kidney disease, recent transfusion, erythropoietin treatment, or recent acute illness, hospitalization, and chronic liver disease. In these situations, we can use like normal finger stick test with normal glucometer, or we can use what is called the continuous glucose monitoring, which we are going to discuss soon. The pharmacological therapy for type 2 diabetes or for diabetes in general, there are few data specifically addressing drug therapy in older adults. However, most diabetes drug trials, including cardiovascular outcomes trials, included a wide range of patients with type 2 diabetes, those more than 65 years of age. Thus, the general approach for choosing therapy is similar in both older and younger adults. All types of oral hypoglycemic drugs and insulin are effective in older patients, although each type of drug has its own specific limitations. So, in general, oral and injectable agents with low risk of hypoglycemia are preferred in older adults. And long-acting sulfonylureas like glycerides may commonly cause hypoglycemia than short-acting sulfonylureas. Those with history of hypoglycemia, multiple comorbidities, or poor functional status should use the short-acting sulfonylureas. Now we are going to move quickly through different types of diabetes medication. We'll start with oral hypoglycemic agents, and we have so many different classes. We are going to discuss them in terms of percentage of reduction in hemoglobin A1C, in terms of hypoglycemia risk and limitation or side effects. The first class, which is biguanide, and it contains the most important drug for type 2 diabetes, which is metformin. It's considered the first line in type 2 diabetes. It causes a reduction in hemoglobin A1C by 1 to 2%. and does not have the risk of for hypoglycemia. First must be used with caution in patients with decreased renal function. Also, it can cause the eye side effects, can cause weight loss, and it also require monitoring for B12 deficiency. The second class, we have this type of antidiabetic, metformin or biguanides can be used as monotherapy. If it is not like sufficient to control blood glucose, we can add another type of drugs. We have glucagon-like peptide receptor agonist, GLP-1, like exenatide and liraglutide. It causes a reduction in hemoglobin A1C by 0.5 to 1.5%. Does not cause hypoglycemia, but can cause the eye side effects. Also, it's used as injectable form, so it required training. It can cause weight loss also, and it's like somehow expensive. Also, we have sodium glucose cotransporter inhibitors, SGLT2, like canagliflozin and dapagliflozin. It causes a reduction by 0.4 to 1.16%. Can cause hypovolemia, AKI, UTI, and genital candidiasis as side effects. And also we have DPP4 inhibitors, dipeptide peptidase inhibitors, cause a reduction in hemoglobin A1C by 0.5 to 0.8%. Does not cause hypoglycemia, but it's contraindicated with history of pancreatitis and need frequent dose adjustment for renal impairment patient. Except linagliptin, it's like safe in renal impairment. Also, we have sulfonylurea. Sulfonylurea is cause reduction by 1 to 1.5% in hemoglobin A1C. But the most important thing is that it causes hypoglycemia, moderate to high hypoglycemia. So it must be used with caution. Also in decreased renal function, and is not recommended if the GFR is less than 30 ml per minute. We have meglitinides also cause a reduction by 0.5 to 1.5%. Also can cause moderate hypoglycemia and require frequent dosing and frequent carbohydrate counting. And the last oral class of drug, we have thiazolidinediones. It causes a reduction in hemoglobin A1C by 0.5 to 1.4%. Does not cause hypoglycemia, but can cause edema. So it's contraindicated in heart failure stage 3 and stage 4. Also can increase the risk of long bone fracture, increase the risk of bladder cancer, and can cause weight gain. Now we are going to, now that what we discussed previously with the oral hypoglycemic agents, now we're going to talk about insulin therapy. Although insulin is not considered the first line for type 2 diabetes, but can be used in specific situations like hospitalization, or if there is a very poor glycemic control. Traditionally, insulin is divided according to the onset of action and duration of action into rapid-acting insulin, short-acting insulin, intermediate-acting, and long-acting. We'll start with the rapid-acting insulin. We have 3 types: insulin glulisine, insulin lispro, and insulin lispart. Also, we have a form of inhaled insulin called Afrezza. The onset of action of all these rapid-acting forms of insulin about 15 to 20 minutes, and insulin glulisine have a peak between 0.5 to 1.5 hours, and insulin lispro peak in 0.5 to 1.5 hours also. Insulin aspart 1 to 3 hours, and the inhaled insulin peak in 1 hour. They have like same duration of action between 3 to 5 hours, and they are like used 3 times per day because it's used with meals. So 3 times or 2 times according to meal. The short-acting insulin, we have regular insulin, onset of action in 0.5 to 1 hour and peak in 2 to 3 hours, and has a duration of action between 5 to 8 hours. And it's like can be taken in 1 to 3 doses per day. And it is the only type of insulin, regular insulin, short-acting. It is the only type of insulin that can be given intravenously. The other types given subcutaneously. We also have intermediate-acting insulin, MBH. Start working at 1 to 1.5 hours, peak at 4 to 12 hours, and has a duration of action about 24 hours. Can be taken once or twice daily. The last category, long-acting insulin, we have insulin Ditimer, insulin Glargine, and insulin Digludec. It's all like have one sort of action between 1 and 4 hours, but they all have no peak or nearly peakless, and also has like the same duration of action, long-acting more than 24 hours. So it could be used once per day, like insulin Glargine. Insulin Ditimer can be used once or twice daily. Also, we have a combination preparations of insulin, which is called the premix insulin. We have a mix between isovalent insulin plus regular insulin in like different concentrations, 70/30. We also have insulin lispro-protamine suspension plus insulin lispro, also in different concentration, 50/50 or 75/25. Also, we have insulin Digludec plus insulin aspart with a concentration of 70/30. All these types of combinations have like a different one set, because it depends on the individual component of this preparation. Also have like different peaks, but the duration is commonly more than 24 hours, and it can be used 1 to 2 doses per day. Now we're going to talk about the basal bolus insulin therapy regimen, which is commonly used in hospitalized patients that require insulin. Insulin is usually added to the ongoing treatment with metformin or other oral antidiabetic, possibly GLP-1 receptor agonist therapy. Rapid-acting insulin may be used as initial insulin therapy in patients with type 2 diabetes. However, it is generally more common to start with a single daily injection of basal insulin. Alternatively, a GLP-1 receptor agonist might be added to basal insulin therapy as the next step, or the patient could be switched from basal insulin to premixed insulin. When using basal bolus regimen, all previous insulin and blood glucose monitoring orders should be discontinued, and any change in insulin order requires completion of this new BBIT first. So how to calculate the basal insulin concentration? It's like generally calculated from the normal or regular total daily dose of insulin that the patient usually take. This total daily dose equal weight multiplied by 0.5 to 1 units per kg per day. So we have to divide this total dose of insulin into about 50% for basal insulin dose and 50% for bolus insulin dose. The basal insulin dose equal 50% of the total body of the total daily dose, and it's given initially as equal twice daily at breakfast and bedtime. And we have to choose for basal insulin. We have to use long-acting insulin like Glargine or Ditimer. For the bolus, also bolus insulin equal 50% of the total daily dose of insulin, divided initially into 3 doses with meals. According to meal, we can divide it into 2 doses or 3 doses, and we usually use a rapid or short-acting type of insulin. And this bolus insulin dose must be stopped if no caloric intake or MBO or bolus feed is stopped. Instead, basal and correction insulin can be continued. Also, patient may determine and administer his own dose and report it to the attending nurse. So it's like convenient and flexible. For bolus insulin, we have to use short-acting insulin, rapid-acting insulin, whether insulin lispro or aspart. So in conclusion, basal bolus insulin therapy remains a relevant option for patients with type 2 and with type 1 and type 2 diabetes that require insulin treatment. In particular, the widely used combination of insulin Glargine 100 unit per ml plus insulin lispro has established efficacy and safety, and should be considered as a first-line option. Insulin glargine plus insulin lispro versus premix insulin as a basal bolus regimen. There is like 7 studies, all using a randomized control non-inferiority design, compared this mixture of insulin glargine 100 unit per ml plus insulin lispro with premix insulin, with the aim of establishing whether premix insulin was non-inferior to basal bolus insulin therapy. Overall, these study results did not suggest any clinical relevant advantage of using premix insulin over insulin glargine plus lispro. Now we are going to discuss blood glucose monitoring while using this basal bolus therapy. At least blood glucose must be checked 4 times per day, 15 to 30 minutes before scheduled meals, and one time at bedtime, as well as where needed if hypoglycemia is suspected. If we find that blood glucose less than 4 millimole per liter, we have to activate the hypoglycemia protocol. And if it is like more than 18 millimole per liter, also we have to activate hyperglycemia protocol. So blood glucose monitoring is crucial when using this basal bolus therapy. Now we are going to discuss hypoglycemia. Hypoglycemia is one of the most important issues, especially in elderly patients, because we know that those group of patients are more prone to experience hypoglycemia. So patient must be educated and trained to follow what is called the 15-15 rule if blood glucose is 70 milligram per deciliter or low, or if they are like experiencing any sign or symptoms of hypoglycemia. So this 15-15 rule is like a simple rule, can be used at any setting, at home or whatever. The patient, if the patient like experience any sign or symptoms of hypoglycemia, or the blood glucose less than 70 milligram, is going to consume 15 grams of fast-acting carbohydrates to raise blood glucose. Then he should wait for 15 minutes and recheck blood glucose again. So it's like working as a loop or circuit. If blood glucose is still less than 70 milligram per deciliter, he's going to take another 15 grams of fast-acting carbohydrate until blood glucose rise above 70 milligram, or until ambulance or medical assistance arrive. Once blood glucose is above 70 milligram per deciliter, or is trending up on continuous glucose monitoring, and the patient won't be eating a meal soon, he can consume a protein and carbohydrate snack. This will help keep blood glucose from dropping low again before the next meal. So these are examples of fast-acting carbohydrates. We have glucose tablets, which is like a small chewable tablets that provide 4 to 5 carbs per tablet. Also, we have glucose gel tube. One tube contains approximately 15 carbs. If these two options are not available, the patient can use anything affordable at kitchen, like 1/2 cup of juice or regular soda, or 1 teaspoon of sugar, corn syrup or honey, or can use hard candies or jelly beans. These are different types of fast-acting carbs. Now we're going to talk about inpatient management of hypoglycemia. We say that if the patient at home can apply this 15-15 rule, but in hospital setting, we have some important instruction and considerations. The glycemic target range for acutely ill patients in the ICU should be 140 to 180 milligram per deciliter, and for clinically stable patients on regular hospital wards, the appropriate glycemic target values are less than 140 milligram per deciliter in the fasting state and less than 180 milligram postprandially. Temporary insulin treatment is generally recommended for hospitalized patients, and if the hospital stay is expected to be short and there is no evidence of metabolic derangement, patient can keep taking their oral antidiabetic medications as they did at home. Metformin should be temporarily discontinued at least 24 hours before any planned procedures, before administration of iodinated contrast media. But emergency surgery is not contraindicated in patients who are currently taking metformin. And for patients with coronary heart disease, the goal of glycemic therapy should be a moderate lowering of the blood glucose concentration with the strict avoidance of hypoglycemia. The current state of data does not support a general recommendation for the intravenous administration of insulin, glucose, and potassium in intensive care of diabetic patients with an acute coronary syndrome. Also, metformin is contraindicated in diabetic patients with advanced congestive heart failure, NYHA stage 3 or stage 4, because it's like causing pulmonary edema. Pioglitazone generally should not be given in patients with congestive heart failure, and there are restrictions on the use of most oral anti-diabetic drugs by patients with impaired renal function. In hospitalized patients, basal bolus therapy yields better glycemic control than simple sliding scales. So how to prevent hypoglycemia? First, insulin secretagogues such as sulfonylurea and meglitinides, as well as all types of insulin, should be used with caution in frail older adults. In particular, older adults beginning dietary or exercise program who are at or near glycemic goals may need an empiric reduction in the dose of insulin or insulin secretagogue to prevent hypoglycemia. Older adults may have more neuroglycemic manifestations of hypoglycemia, like dizziness, weakness, delirium, and confusion, compared to the other types of adrenergic manifestations like tremor and sweating, so resulting in delayed recognition of hypoglycemia. These neuroglycemic symptoms may be misdiagnosed as primary neurologic disease, such as transient ischemic attack or delirium, leading to underreporting of hypoglycemia episodes by patients. Hypoglycemia also can result in poor outcomes such as traumatic falls, adverse cardiovascular events, and cardiac autonomic dysfunction. Severe hypoglycemia requiring hospitalization has been associated with an increased risk of developing dementia, although the mechanism is unknown. So these are the recommendations of the American Diabetes Association to prevent hypoglycemia. First, addressing episodes of hypoglycemia at routine visits, because older adults with diabetes have a greater risk of hypoglycemia, and also recommending continuous glucose monitoring for older adults with type 1 and type 2 diabetes on insulin therapy to improve glycemic outcomes. Finally, considering the use of automated insulin delivery systems and other advanced insulin delivery devices. So what is this CGM, or continuous glucose monitoring? It is a wearable technology that tracks blood glucose level over time. It measures glucose level in the interstitial fluid 24 hours a day while wearing the device, and it's have like three main parts: the sensor, the transmitter, and the receptor and the receiver. The sensor is like a device inserted under the skin that measure blood glucose level in interstitial fluid, and the transmitter that transfer or send data from the sensor to the receiver, and the receiver that it's like a screen or display that display glucose readings on phone or on a dedicated device. And these are the key features of continuous glucose monitoring, or advantage of this technology, is that it provides real-time glucose reading every 1 to 5 minutes. Also, it shows changes in glucose levels if glucose is rising, falling, or stable. Also, it gives alerts in cases of hypoglycemia or hyperglycemia. Also, it measures what is called the time in range, TIR, which is the percentage of time a patient's blood glucose stays within a target range, and it's usually 70 to 180 milligram per deciliter for most adults. So, advanced insulin delivery devices have been shown to improve glycemic outcomes in small studies conducted among older adults. RCT, randomized controlled trial of older adults with type 2 diabetes, using multiple daily injections who were unable to manage insulin therapy on their own demonstrated an increase of time in range, TIR, of 27% over 12 weeks of automated insulin delivery. Of automated insulin delivery use in addition to tailored home healthcare services. So these devices or technologies help to increase this TIR. Okay. The final part of this session is that we're going to discuss the management of diabetes across the continuum of care. We have so many special settings. If the patient is independent or residing in assisted living setting, we have to use a stepwise approach and involve family members or caregivers. Also, we have to consider support availability from the facility staff. In hospital, as we discussed, the risk of severe hypoglycemia and mortality are increased with tight blood glucose control. So strict glycemic control is not recommended. Also, we must hold on all non-insulin therapies, and insulin for persistent blood glucose more than 180 milligram per deciliter, and adjusted to target 140 to 180 milligram per deciliter for critically ill and non-critically ill patients. Also, the use of basal bolus insulin with or without correction regimens lead to a better glycemic control than a sliding scale alone. Hypoglycemia protocols for blood glucose less than 70 milligram per deciliter must be activated, as we previously discussed. And also, we have to communicate with outpatient provider in case of discharge. For patients living in a skilled nursing facility, we found that 1/3 of these patients have documented hypoglycemia, also may have less regular food intakes, and establish protocols to alert medical providers so that management of diabetes can be assessed and adjusted as necessary for hypo or hyperglycemia. In palliative or hospice care facilities, this strict approach to glycemic control, and in a stable patient, we have to prevent hypoglycemia and symptomatic hyperglycemia, which can lead eventually to dehydration. Also, we have to titrate down insulin dosage as oral intake declines in case of organ failure. In critically ill patients or dying patients, we have to stop all agents in type 2 diabetes, and we have to decrease the amount of insulin in type 1 diabetes. So, in summary, diabetes is important to identify and address because of the great heterogeneity in older adults, and the treatment goals for diabetes must be individualized. The risk of hypoglycemia should always be considered, and diabetes self-management and education are important parts of diabetes care. So that's all. Thank you.
Thank you very much, Dr. Ziad and Dr. Mudathir, for this informative presentation. Is there anyone here who have any question? Feel free to ask any question. Okay. Since we don't have any question at the moment, we will move to the next topic. Let me share my screen first. Okay, can you hear me clearly and can you see the screen?
Yes.
Okay, thank you very much. Now, good evening, everyone, and thank you very much for this opportunity today. I'm going to talk about how to create a research proposal using Google Gemini Deep Research. Okay, so we'll be talking about AI-assisted academic writing. Okay, So why this is important? We all know that as doctors, we are expected always to engage in research, and writing research proposal is the first and main and the most important step for scientific research. There's an increasing demand for high quality proposals, and then sometimes we might face an issue of limited time. Okay, so we need these tools, AI tools, for efficient research. Okay, so what is Deep Gemini? What is Gemini Deep Research Tool? This is a new tool. As you all know, that Gemini is artificial intelligence related to Google company. Okay, so they invented a tool to help researchers all over the world. Okay, so this tool helps to generate structured research outputs. It synthesizes multiple sources, and then this AI deep research tool have evolved from simple chatbots to specialized agents capable of automating the most labor-intensive parts of medical research, such as literature screening and data extraction. Okay, so it was mainly designed to help us to deal with the time-consuming parts of research like literature review and data extraction. Okay, so here we've got some examples. For example, in systematic review, it can help to screen thousands of abstracts. Okay, we're talking about here, and then to screen thousands of abstracts in a very short period of time. It will also help in data extraction, okay, like p-value outcomes from the PDFs that we share with the AI tool. And then it could help also in drafting and writing, okay? Okay, so because it has this structuring manuscripts, summarizing complex findings. Right, so now, what is research proposal structure first? Of course, we all know that every research proposal will be made of titles, and then background, research questions, and some people say it's objectives, and then methodology, and expected outcomes, of course, and then references. Okay. So how can we use this tool in Gemini effectively? First, you will need to define the topic, the research title that you're looking for, okay? Then based on your input, the system can generate a research plan, can help you in your plan, okay? So basically, the research proposal is a plan of what type of research you are going to do, and this Gemini tool will help you in generating that plan, okay? So how can you use this AI tool effectively? Be specific and structured, okay? The quality of the output from this AI tool highly depends on the quality of the input that you gave, okay? So if you provided vague instructions, then the result will be vague, of course. So you have to know what you need, what you want exactly. So unless you know what you need, the AI will not be able to help you with that, okay? And then it will help you to include the population, interventions, outcomes, everything. Right, so now we come to the strength and importance. So we all know that it saves time mainly, okay? It's very effective. It improves the structure of the research proposal, generates references, and support idea generation. It supports the idea generation. It does not generate the idea. You'll have to generate the idea by yourself, but then it can support the idea with more structured outcomes, okay? Now we come to the limitations. The first limitation would be potential bias, okay? As research tools are still developing, okay? They are not 100% accurate. They're not 100% effective. So you should keep in mind that there is a percentage of potential bias. The second limitation would be it requires validation. You have to double check. After it generates the results or the output, you have to double check just in case the orders were misunderstood or there was an input error that will generate an output error eventually. Okay, so you have to validate the results in the end. It's not a replacement for expertise. You should never replace critical thinking or expert judgment. While AI can summarize and extract, it should assist and not replace human review. Okay, so there are some models of AI. Okay, it still requires human in the loop validation to prevent hallucination. So hallucination is like a condition where AI can go further away, okay, from the point that we are exactly looking at or looking after. Okay, so to prevent that and keep in target, keep it to the right path, to the right way, we'll have to still, validate the results. So for best practice, we can use AI for drafting, then validate with databases, apply appraisal tools, and edit critically. Here is an example. Okay. For example, we have a topic of reducing hospital readmissions. What Gemini can help you with is that it can help generate hypotheses and suggest designs and identify key variables. Okay. So it's a systematic review topic, of course. So generally, systematic review can take months, okay, to be finished or completed. With the help of AI tool, it will take days to weeks. Okay. Now, we need to keep in mind these ethical considerations when using AI in research proposal or in any research topic generally. Okay, we need to keep these ethical considerations, which are transparency, avoid plagiarism, maintain authorship integrity. Okay, this is your responsibility. This is the author's responsibility, not the AI responsibility. So you have to keep that in mind. We have another example for ethical consideration here. In cross-sectional studies involving patients' data, only use HIPAA-compliant versions of AI, like ChatGPT Enterprise, that do not use your data to train their models. So we all know that AIs, okay, all artificial intelligence tools, they use our data to train their models, okay? So we need to be very careful about that. We need to be very careful about the patient's data and sharing data with AI, okay? We have to only use HIPAA-compliant versions of AI, okay? This is a very important ethical consideration. Now, the key takeaways from this topic today is that AI enhances the speed, the structure, it's very effective and efficient. We should only use it as a co-pilot. It's not a replacement, and critical thinking remains essential. Any questions so far? Okay. Right. So if there is no question, we can thank you very much, everyone, for listening. I hope this was very informative. I hope it helped you out generally in your future research proposal writing and projects. Okay. Now we can move to the next topic. Okay, it will be SPSS. The next presenter can proceed.
Hello, Dr. Aya. Hello, Dr. Nadir. This is Nabiha here. I am going to present my presentation on SPSS. Just let me share my screen. Just a moment, please. Okay. All right. Am I audible?
Yes, everything's clear.
All right. Hello everyone, this is Nabiha and I'm going to give my presentation on SPSS. It's basically on how to download and how to use SPSS, especially for the beginners. Just a minute. Just a moment, please. I don't know. Okay. Just a minute. I cannot see my presentation. Just a moment. Okay. So here we are. So what exactly is SPSS? So it's the short form of Statistical Package for Social Sciences. So this software was originally founded in 1968 for the behavioral sciences students. So the psychology students, when they used to have their research and they had to present their data, they used to use SPSS. But over time, it began to be used for more departments and more um, places as well. And ultimately, it became IBM SPSS statistics that is used widely throughout the world, especially in the academia, and help people learn the statistical analysis, especially for the beginners who are just starting with their statistics and research. So why is SPSS so popular? One of the most important reason is the user-friendly interface and that it makes data analysis very simple and efficient. So ultimately, the research is efficiently done, the analysis is efficiently done, and people's life become easier. But at the same time, it is sometimes criticized as well because sometimes the beginners do so many of the analytical um, data analysis that it becomes overwhelming for them to handle it. But then again, it's a software that is there to help beginners learn, and that is a reason it is very popular, especially in the academia. So we'll now look at that how do we download the SPSS. So we go to the IBM website, and there's this IBM SPSS software that we can download. There's a free trial of 14 days, and it's free, so it's quite user friendly. If you can see this website, there's try SPSS statistics for free. So by clicking onto it, we can go on to the free trial. And here it is going to ask you to either sign up with your Google account or make an account. And once you do that, it is going to give you a link to download the SPSS software, and you can have it free for 14 days, after which you have to buy the subscription. Okay. I'm sorry. Is my presentation visible? I'm not sure if there's website visible or my presentation.
So the presentation is visible and the Excel sheet is visible as well.
All right, I get it. Okay. So now how to use the SPSS. The most important thing is to understand the SPSS interface, and there are two views, the data view and the variable view that we are going to look at now. So this is our data view. So here we can see at the top bar, file, view, data, transform, analyze graphs. So by clicking onto the file, we can either go to a new data interface, and then we can start putting in the data. Here at this bar, there are multiple variables that we can add, and these are the data and the values that we can add. I'll in a short while go into the real software and we'll see how we can add the values. And then we come to the variable view. In the variable view, these are the characteristics of the variables that we are going to look at. The starting is the name. So the name has to be without any spaces. There cannot be any special characters that can be included here. No numbers can be included. Then comes the type, what type of variable. The word means how long can be a variable. If it's a numerical variable, how many digits can be there, or if it's a variable with alphabets, how many alphabets can be there. Then comes decimals, how many decimal places you think the variable needs. Then the label. Label is basically a description of the name. For example, if you say age, so the label can be age or age of participants, and spaces can be there in the labels unlike in the name. Then comes the values. So the value of variable is most important when we're talking about the categorical variables that we're going to talk about in a while. The missing variables, for example, if there are missing values in your data, so that would be added here. The column is just the width of the variable. If you look in the previous slide, so it's just how wider you want your column to be. Then alignment, do you want your variable to be in the center, towards the left, or towards the right? Then the measure. So there are three different measures of variables that we're going to talk in a while. And then the role of the variable. What exactly is this variable? Is it the input? Is it the output? So that too we are going to see. Here, this is just a quick description of what we have already discussed. The name, no spaces, no special characters, no number, and the name must be unique. Again, we are talking about the variable type now. So these are the common variable types that we often see in the SPSS. So the numerical variable type consists of numbers, and these numerical variable type can also denote categorical variables, which can be nominal and ordinal. And nominal and ordinal variables we are going to talk about in a while. Then comes the string type. So string type is basically a text. It can be composed of alphabets, phone numbers, or zip codes. Now we can think that phone numbers and zip codes consist of numbers. So why are they in string type? And the reason is that these numbers are very random and they don't really make sense. Like for example, if we talk about age, so there is a specific sequence to the age. So it's a numeric variable. But if we talk about phone numbers, so these are the random phone numbers. These are the random numbers that make up a phone number. So it'll be a string type. Then if the variable has comma, it can go into the comma type, the dot type. If your variable consists of dates, so the date variable type would be chosen. And then dollar, if you've got a variable that has dollar as a currency. This we have already discussed about the variable word and decimals. We have discussed about the label. The important point is that whenever you are going to see the output, so it is going to have the label and not the name that you had put. Now we were discussing about the values of variables, and I said we're going to discuss it a bit later. So values are for coded categorical variables. What is coded categorical variable? For example, gender, for example, race, or the level of education. If we talk about gender, for example, so each value is going to have a label. So if we're talking about gender, so value 1 and value 2. Value 1 we can give randomly to male and value 2 to a female. And then comes the level of education. This is another type of categorical variable where we have got values 1, 2, 3. But this time it has to be in an order. So the minimum level of education is middle school. So the value of 1 is going to be towards middle school. Then 2 is going to be towards the high school. And then the highest level of education amongst these three is college. So level 3 is going to be college. Now, we are going to see the value measurement. So for the numerical variables, there are three value measurements: scale, ordinal, and nominal. Now, scale is for a numerical value that is continuous. For example, height, age, number of people. But ordinal and nominal is for the categorical variables only. Now, we'd be talking about categorical variables in the past two slides, and we need to know what exactly is nominal and ordinal. So, when we talk about gender or race, tribe, religion, these are the random variables. So, these are nominal. It means that the value does not need to be in a sequence. For example, when we talked about gender, value 1 we gave to the male and value 2 to the female randomly. We could have done opposite, like value 1 for the female and value 2 to the male. But ordinal is ordered, and these are the meaningful categories. For example, the level of education, and that is exactly what we did here. Value 1, 2, 3, and starting from the least, middle school, and then high school, and then the college. So that is the difference between nominal and ordinal. If there's a meaningful category ordered, it's ordinal. Otherwise, random, it's nominal. And if we talk about the string variables, which is text-based, so in that scenario, the scale measurement would not be there, and only ordinal and nominal would be present. Before we go further, I want you to see a software, the real software, so that we have a better understanding. Let me just show you. Okay, so here is the real software, and we can see that this is the data view, and these are the variables that have been added. For example, name, age, gender, sports, smoking, education. We can add any variable here, and then when we add the value, for example, 1, 2, 3, we add. So it'll automatically add another variable to it. Now we come to the variable view to understand what exactly are these characteristics. So first of all, we said the first variable was name. It was a text type, so we chose string here. And width 8, decimal 0, and then it's a bit detail of what whose names are these. So these are the names of participants. Then value, since it was not a categorical variable, we chose none. There was nothing missing, so we chose none. And this is just the width alignment. And then the measure. So the names are just random names, right? So we chose order. And since it was string type, it was only ordinal and nominal that we could choose from. And then the input. Then we had the other a variable age. Again, it is numeric. The values none, and then it is scale. Why? Because it is continuous. It is not categorical. And then comes another variable, sports. Now, the label tells you what exactly about sports are we looking at. So here it says, did you play sports in the last 6 months? And we gave it two values, either yes and no, so it's numeric. And then how do we put the values? Here we can see we gave value 1 a no and value 2 a yes. And why did we do that? For example, when we were making this data set, it was about physical well-being. So people who were playing sports were at a superior level than those who were not playing sports. So we gave value 2 to people who played sports. And I chose a mayor ordinal for it. And similarly for smoking, do you smoke? If they smoke, so the value 1 for yes and value 2 for a no. And then again, I chose ordinal because if they don't smoke, it's superior than if they do smoke. And then comes education. We had talked about this earlier as well. And we can see that how we have arranged the values here. Value 1, middle school, 2, high school, and 3, college. And again, this is ordinal. And this was the variable that we just added, and we can adjust it. Also, the decimal would be 0. It would not be 2. All right, so let's get back to our slide. Okay, so now once we're done with the variable entry and understanding the characteristics, so now we need to use the data interface and do the data entry. For this, it is better to turn on the value labels mode on before you start putting on your data. And if I show you here, in the data view, so we had chosen female and male as 1 and 2, but because I had opted for value label icon here, I could choose female. You see, it's value 1 male and value 2 female. So I simply chose female. It is to make our work easier and to avoid any confusion. Similarly, if we see smoking here, so we had chosen value 1 for a yes and value 2 for a no. So we can simply say have a yes here rather than being confused in 1 and 2 and going back to the variable view and see what we had chosen. So this is just to make our work a bit easier. And once we're done with the data entry that that we can see is being done here, we can analyze the data. Now, how do we do that? There are multiple things that multiple icons that we can see, especially the analyze and graphs. If you click onto the analyze, there are different and multiple analytical techniques that is present here. And you can choose any one of those. For example, power analysis if you want, means if you want to do t-test, you want to see proportions, if you want to go for frequencies, descriptives, you can go for descriptive statistics, or if you directly want to go to graphs, you can also click onto graphs and choose the type of graph you want to go for. So I'm going to just give an example of a frequencies we can opt for. Let me quickly, okay. So I chose two variables, gender and do you smoke. So how do we do it? For example, if I want to if I want to get a frequency of how many people play sports, I can also add this onto this. So now I'm going to say okay, and it is going to take me, I'm not sure, let me see if you guys can see this. Okay, so here you can see now, just a minute please. Okay. All right, so you can see here now that it has given us a graph, a bar graph with gender, a bar graph with gender here. And then do you smoke or not? How many percent of the participants smoked and how many percent did not smoke? And then did you play sports or not? So what is the percent of participants who played sports and how many did not play sports? So we can easily see here. Now the good thing about SPSS is that we can easily copy the graphs and export the tables and the graphs and our analysis from here to wherever we want them to be used at. For example, if I copy this one, I can use it later. Let me get back here. Okay, so here is a quick review of what we had already seen in the real software. We click onto the analyze button on the upper bar, and here is all the different techniques available to us. We can easily export and save the analytical graphs, bars, and tables. And I talked about using an example. So, for example, I need to show the percentage of males and females, so I can easily paste the table here. And likewise, I can use it anywhere I want. So that was the point. And okay. All right. So that is about it, I guess. We have covered everything from understanding what is a data view, what is a variable view, how do you classify variables, how do you enter data, and then how do you start analyzing it, and then also exporting our analysis to other um, documents or other places, or maybe even websites. So these were the reference I used, and well, thank you so much. That's about it.
Thank you very much, Dr. Nabiha, for your presentation. It was very informative and helpful. Is there anyone here who have any question for Dr. Nabiha? Okay. Thank you, everyone, for attending. Thank you for listening. Thank you very much, Dr. Nadir, for this opportunity as well. Now we came to an end to our presentations today. Thank you.
Thank you so much, Dr. Aya, and thank you all presenters. You did a great job, wonderful presentations, and hopefully this will help some of the fellows in this program. Any updates as far as your projects, research projects, ideas, how far you are in your task, and if there is anything you want to share, please go ahead.
Hello, Dr. Nader.
Hello, go ahead, Dr. Malaz.
Okay, firstly, I want to share conference book of our mobile app presentation, abstract,
Yes.
sorry. Actually, Dr. Nader, also I faced another issue with adding like primary order and so on, but Alhamdulillah, it was solved. And then they was changed it, and they was shared with me, and I shared with them in the group. I'm also actually, Dr. Nader, I'm planning to submit it for the journal to publishing and so on, but I need your advice regarding journals and so on, like to suggest any journals.
Sorry, Dr. Malaz, I stepped a little bit. I didn't get your question. Sorry. Can you repeat?
I want even thought to submit it for journals to publishing and so on. Can you hear
You
me
want to
well?
submit it? Yeah.
Yeah.
Mm-hmm.
So I need your suggestion even so regarding that. So
Yeah, I think it's a good idea. So
mm-hmm.
there is a few tools that you can use to have a list of journals that can accept similar article. So what you can do, one of them is Jane, Jane, Journal Finder. And that's a tool where you can just copy and paste maybe the abstract or some of your key points in the paper and paste it in the box, and it will basically analyze it and see which journals deals with similar keywords and the chance that you can apply or submit to these journals. Have you used
Okay.
it? Have you used Jen?
No.
So it's a simple website where you can open. You want to do it right now? Maybe we can share it so that others can know about Jane. Go
Yeah.
to the browser, either
Mhm.
Chrome or any browser, Internet
Okay.
Explorer,
Yeah.
and then search for new tab, and then go for
Alright.
Jane, Jane.
J-A.
No, J as in
Oh, okay. J, yeah.
James.
Okay. J-A.
N-E
Mm-hmm.
space journal finder.
Okay. Journal.
Mhm. Finder. And
Okay.
click OK.
My internet is not that much good.
That's all right. Let me try. I'm gonna share my screen just a second.
Yeah.
Okay.
Okay.
Let me just. I will go back to your screen in a second. So
Okay.
this is when you say Gen Journal Finder, it will list you this and maybe other options, but it's called Gen biosemitic or something like that. And it has three or maybe four options. Find a journal, find authors, or find articles. So my interest here, you already have an idea, you already wrote an abstract, or maybe you started your manuscript. So what you're gonna do is you're gonna copy the abstract. Let's pretend this is abstract. You're gonna copy it and paste it, and it will have some of the keywords in your like the FIRE app. It will talk about international medical graduates in nursing homes, in emergency situation, and emergency plans. Let's see, these are the keywords, for example, in your abstract. When you hit find the article or find the journal, it will list you some of the journals that will accept or will deal with similar topics. And you can look at on the right side here, the impact factor, I think. So you can see which one is closer to the topic. And then when you click on it, you can just copy it and see if you can get the author. Vista is in Chile, but let's say JAMDA is one of the journals that can accept similar article. So you go to their website, and it will have, most of them will have author guidelines, and when you click on it, it will give you a list of in this I don't have access, but it will give you a list of the requirements for you to submit your article. So they want you to, let's say you have an article about this topic, at least you will have 5 references or how many, and the topic is supposed to be in the form of an abstract. Then the details of the abstract will be background, method, and data analysis and conclusion or discussion. This is basically what you will find, and you can submit to that journal, if that makes sense. Sometimes they will ask you to format the references in a specific format. There is Chicago format, for example, or there is APA format, something like that, if that makes sense. Thank you. I'm gonna stop here.
Thank you so much, Dr. Nadir.
You're welcome. Okay. You can go ahead if you want to share your screen, Dr. Malaz, and if you want to tell us more about how far you are doing.
Yeah.
Thank you. I need to stop this.
Okay.
Mhm.
Here's actually our next project about blood pressure. Okay.
Can you share
Can,
your screen? Because I can't stop my screen for some reason. I don't know. I stop screen. Okay. Now you can share your screen, Dr. Malaz.
okay. Okay. Actually finished the data, the apps review and so on. Okay. And it's about, I think, 9 to 10 apps till now. Okay. Included. And I calculated even so wait, it's data set. Yeah, here. So I calculated the clinical utility score distribution. I did the histogram for it and feature availability across the score for the 4 features, and the even so the platform comparison of clinical utility scores. So, and then actually regarding the results, Dr. Nadir, I want you to check it, please, because I changed the you can say the percentage, okay, regarding our results. So, wait, because let me back to my Google form because I edit it in my abstract. I think so, this one. Yeah, it's here. So, based on our results, we have total 91 apps, okay, and like the majority of them supporting for the blood pressure logging, 97.8, and even so, Dr. Nad, the crisis alert was 0, okay, for all apps. And regarding the clinical utility score, the main clinical utility score is 5.05, and I calculated the mean deviation, the standard deviation is 1.81. So you can revise it if I missed something.
Wait, hi, Dr. Malaz. I wanted to ask you a question actually, because we also had like a group who were responsible for also the COPD app. I wanted to ask you as to how did you measure the alert for the crisis or the hypertensive urgency? How is it exactly measured? Did you try the app itself or how?
For what? Sorry?
like, did you try the app? How did you where is this? Here it's written like critically 0% of the apps provided alerts for hypertensive urgency or crisis. Is this did you guys try the app?
Tried the app, you mean?
Yeah. Like,
No, not tried the app, but actually you were gonna check it as we do it, like regarding the features and so on. Like if you're going to the apps and so on and using even so like the apps features you can say, or the apps how the apps is working and so on, and even so the AI like we're gonna help you to use, like as Dr. Nadri was added there, you can use this. Okay. So you will gonna
yes.
ask if the crisis alert, okay,
Oh,
is it yes
okay.
or no?
Mm-hmm.
Okay, is it yes or no? And based
Yeah.
on that, we're gonna give you all the
All
features.
right. I see here. Can I ask? Just like I'm really curious. It's written here Python code. Did you guys use Python?
Sorry?
It's written down right next to all data. Did Python code? Did you guys use Python for this?
Yeah,
Really? Hmm.
yeah.
How was it
Actually,
used?
Dr. Nadir did not me. Dr. Nadir added it actually, all the Python code.
Nice. Okay. I was really curious because I don't know what happened to it, but like I also made an Excel already, and like I was responsible for the iOS apps for COPD. Unlike your apps, which is related to blood pressure, our apps had
Mm-hmm.
little to no reviews. So I also wanted to ask on that regard, how did you deal with I mean, seeing your thing, it's like you guys have a lot of reviews. I even saw like here, like yeah, it's literally like in the thousands. For us, it was less than maybe 50 or 10 if we got lucky.
Oh,
So that's really nice. That's
actually,
really nice.
yeah, it's okay. Actually, I don't know, like regarding the all of you. Maybe actually, I find even so a lot of apps like repeated and so on. I checked again like all the apps after
Yeah.
edit all apps there, okay, in one sheet. So I review all of it again.
Yes.
I found like some you can say four or three like duplicates and so on,
Yes.
and even so like one or two was included wrongly, even so don't let me the criteria of blood pressure logging and so on, and yeah, based on that I review all of them again, and yeah, it was good actually till now.
Okay, so when
Even
the app's
so
over,
tahleel,
uh,
sorry.
that's a really good. But a question. So if apps overlap, so if say like a BP app is available in iOS and it's also available in Android, how did you guys deal with that?
How what?
How did you guys deal with this? Like if the app is available in both iOS and Apple. No, Apple and Android.
Apple and Android, so this will
Yeah.
gonna be one app.
So you're gonna consider it as one?
Yeah.
Okay, nice. Okay, thanks. Because here it's yeah. Nice, thanks.
Yeah, it's okay. So yeah, even so, you can tell you how I calculated all like here. If you were gonna go with me, okay. So let me show you. So here I added like the formula you can say to count for me, or the clinical utility score average, okay, which is our main from V2 to V9 to N up, okay. And even so here I added the formula to calculate for me the standard deviation, okay, for all our clinical utility score. And here, because like we want to know like the feature availability across apps regarding this blood pressure logging, physician sharing, medication tracking, and crisis alert. So I go in here, okay. So I even so added a formula to count for me, okay, which is app having the blood pressure logging. So should calculate for me any G from G2 to G1 having Y, which is mean yes, So it was 89. So that is why I told Dr. Nadir, for me, we have 97 point, I think 6% of the apps having blood pressure logging. And regarding the medication tracking, when I did the formula, even so to calculate, yes, just about 30. And crisis, it was 0. Okay, alert, reminders, even so 52. And regarding the physician sharing, around 59. Okay, and then if you go here, you will gonna find here, I put all of them in table, okay, and then I insert, like, as you will gonna find here, like, I added, I highlighted it by green, and then I insert, you can see, chart. So we're gonna use like blood pressure and so on. So to be, you can say from the bigger to higher, even so, like, I ordered them, okay, based on that. And even so for the iOS and Android, because I want to compare between them regarding the average score, what I did, you will gonna find here this one for the iOS. I wrote formula, okay, to calculate for me. I tell the formula I want average if B2 from B2 to B91. So here B2 and B91, what is it? It's our platform, right? I told him calculate for me average score, okay, for any platform from B1 and B2, you will gonna find Apple. And the same it for the Android. Get my idea? So we're gonna first calculate the main average score, okay, for the B1 for the any app like in Apple platform, and again for the any app in Android platform. So it was 4.8 and 5.4, or 4.84 and 5.43. And then same, I put it as in table and so on, and then I selected, and then I inserted the chart. Okay. So, and regarding the score distribution here at histogram, just we're gonna like highlight, or you can say selected the clinical utility score, and then you will gonna go to the chart and insert histogram. Okay. If you get me.
Yes, beautifully explained. Thank you.
Okay. So based on that, I changed it like here. You will gonna find our result. I changed it here. So yeah, that's what I did actually.
Oh yes, and I forgot to say congratulations on the abstract and the conference.
Thank you so much, Jane.
Excellent.
Okay. Dr. Nader, even so, I need your advice regarding submission and so on. Okay. If you're going here with me, you're gonna find the options. If we're going to the submit abstract and so on. Wait, no, I started here to going the. So we have two options regarding the awards, and if you're going to the update contact, let me actually show you here, because I need your advice. Is it better to submit it as abstract just, or like doing the poster? Because here we have two options. If I select oral presentation, they will gonna ask here to like to submit like official supervisor letter and so on. I think they requested Dr. Nader to have higher degree related. So I think as part of fellowship, I can submit and can apply for it. And same poster, like for oral and poster presentation, like they requested to submit like official letter.
That's fine.
And
Yeah, I can write
yeah,
you the letter. Yeah, that's you can submit it as oral presentation, and
yeah, it's better than poster. I don't know.
so
So I
the
need your
weight,
advice regarding it. Mm-hmm.
yeah, the weight when you present oral
Mm-hmm.
presentation is better than only a poster presentation. Uh, as far as the impact or the weight. So it goes like if you publish an article in a journal,
Mm-hmm. Mm-hmm.
that's gold. Then you go to silver, that's an oral presentation. Then you go to bronze, that's the abstract, which is presented as a poster.
Oh,
So the easiest
good.
for all people to present a poster, they will accept it,
Mm-hmm.
and it will be just a few minutes presentation for the if they have judge who will come and ask you a question and see who will be the first like winner.
Mm-hmm.
Um,
Mm-hmm.
Above that, it will be the oral presentation, which is a bigger one. You will spend 20 minutes, 15 to 20, about the topic, and then
Mm-hmm. Yeah.
the price will be larger or uh, more. And then if
Mm-hmm.
you submit your work as a paper, it's
Mm-hmm.
more impactful.
Okay. Okay, so that is good. I'm gonna select our presentation. Okay, and regard the requirements, Dr. Nadir, also I need your help. I'm gonna write like my statement and so on, and all the documents they requested, and I'm gonna share it with you. So you can give me like your advice and so on, and then I'm gonna go and edit it, inshallah.
Inshallah, no problem. Yes, anytime. That's great.
Okay, so I think there is another thing. Oh, okay, yeah, Dr. Nadir. So I want even so to ask you, I think there was something related to the posters. I'm sorry, wait. I'm not here in the step. Um, I'm sorry, Dr. Nader. Actually, I put all of my thoughts in your Google Sheet.
That's okay. Sure.
Oh yeah, here, Dr. Nader, can you just like actually here regarding the designing the poster and so on. So
If
just
you
can
submit it
you
as an oral presentation, you don't have to design the poster. It's gonna be most likely like what you are doing now. You are just gonna do PowerPoint slides about the topic, and you're gonna talk about your topic. If they accept it as a poster, sometimes this happen when you submit as oral presentation, but they have a lot of good topics and yours is not as good, then they will convert that into poster. Then you can go by their defined features or requirements to make your poster like the size of the poster. And then you can use any templates to build or just copy paste your data, graphs, and so on,
Okay,
tables.
okay, okay. So also Dr. Nadir, regarding the like we can do up, right?
What
We
do you
can
mean
do
app?
we can create up like based on
Yeah,
our
app, mobile
yeah,
app, yeah. Mhm.
yeah, I'm sorry.
Yeah, sure, yeah. So that's the next step. So the first small step is to convert whatever we are working on to an abstract, or in this case, maybe oral presentation. A bigger step to convert that into a paper. So you submit that and a manuscript to a journal, and if accepted, published, that's like a paper publication. The more innovative way is to build what you found into an app and to meet the gap or to meet the features that are requested. Or if you identify any new ways of improving whatever available in the market. So that would be the next step. So yes, and developing a mobile app with great new features, that would be also a possibility. There is a way to develop it faster using AI as a web-based. Then you can convert that into Android. It's easier, and then you can submit to Google Play. In the past, we did that, and we were successful, like building 5 apps and accepted in and published in Google App. The Apple app kind of requirements and the process is longer. And the dental group, they published an app, but they were able to recruit or ask like programmers to help with that process. And I think the programmers were the people who publish it in the Apple store. So kind of a tricky. I think there are some tools where you can create the web-based app, and I'm not sure how much it costs, but some of them they will be able to push it to both stores. Yeah.
Okay.
So
Can I
we can
ask?
help you. Yes, yes,
Can
go
I
ahead.
ask Dr. Malaz, how do you plan here? Clearly, there's a gap in identifying hypertensive urgency or crisis. So how can we do that if we collaborate with AI per se? But I think this is more of a programming thing because I think the Apple Watch has successfully or is able to actually record arrhythmias now within like and actually it's even able to take blood pressures like accurately. So how can we realistically propose an application that is able to fill in the gap, which is like being able to read hypertensive urgencies or crisis without an actual thing to measure it? How can
Without an actual what?
without a thing to measure it, like for example, like an Apple Watch is used, and they've said that it's been found that like an Apple Watch is actually able to detect what they call that high blood pressures or like the BP in general or pulse rate. So how do you plan to make an app that fills in the gap here in your research, which is it lacks the part of it being the
Crisis
applications.
alert.
Yeah, the crisis. Yes.
Actually, like the app, I saw the app is not just like just focusing on crisis alert. Maybe crisis alert you can say you're gonna be related to the like the scores you can say or the the blood pressure itself. You get me? But my idea in general because what I saw mostly of apps just like you can say following the AHA you can say or ESH like in just blood pressure logging and so on. Even so there is no AI feedback there or there is no AI features there. And even so, regarding the education, there is no education like in mostly of apps. And regarding the crisis alerts, I don't know like how it should be. You can say reach it as like alert how it is gonna be check the crisis. But I think like maybe even so like within the blood pressure logging they can app can alert for crisis and so on. Yeah, Dr. Nadir? I don't think actually, I'm not sure.
So thank you, Dr. Lujan. So when you talk about the wearable like the Apple Watch or different watches, then you are talking about technology That's, as you said, can detect AFib or tachycardia or other arrhythmias, and as you mentioned, maybe blood pressure and other oxygen level and so on. So the approach to use a new app that will cover the gap. So the gap will be all these devices that are smart and wearable, mostly cost like 500 or more. And we are talking about the rural communities or other people who cannot afford to have these devices. So using their own blood pressure devices at home, and then if they record, we can either automatically talk to the machine or they can log the information, and then you can put algorithm where you will say if blood pressure is more than 180 190, then show either using the AI, or you can program it as can you go over these symptoms? Do you have headache? Do you have chest pain? Do you have this? And if any of this is positive, then you will show them an alarm on an alert that they need to contact their family
Primary care
doctor or
provider.
PCP or
Yeah, thank you
So
so
this,
much.
yeah.
That's actually brilliant, actually, and needed as well, and
Yeah.
fills in the gap as well without being
True.
expensive. Yes.
So my idea is you want to reach as much as possible to fill the gap and, if possible, prevent a problem from happening or uh, solve an issue. In Germany, I think a few years ago, they had an app that was also developed for rural areas. I don't remember the features, all of them, but mainly patients on rural areas to have an EMS come to them, like the ambulance. Then they can use the app so that they can track certain things and communicate. It's like before COVID, we didn't use telemedicine as much. Nowadays, we're using telemedicine. So the patient will be in their home, the EMS or the ambulance will come, and they can communicate to the doctor in the ER or the emergency room. If they want to look if the patient has a stroke, they can remotely know that, examining the patient before even arrive, or if they have chest pain, then they can prepare the catheter lab, something like that. And they got funded from not the health department, but agriculture department. So it's kind of interesting to share with you. Thank you.
Okay, that's very actually interesting. Thank you. Dr. Nader, I kind of have a more like another question on my on my situation. So I am currently situated in a small town in Saudi Arabia, but I also want to, I'm targeting to match for like next year, not this year, because I want to build my CV. I find that here in the rural area, I find that maybe because Saudi Arabia is a rich country compared to Sudan. So I paused my internship because I'm not sure where to go or what to write in my CV now, because like I want to build it directly so that it could be suited for the US pathway. But I'm rather confused. Like, would you advise me to go to a bigger city so that I can have access to more volunteering stuff? I even considered going back to Sudan, but the situation is truly, truly still unsafe. It's still unstable. So, would you advise me to go to a bigger city in Riyadh so that I could participate in like maybe like volunteer work and etc. Or how do I go with this?
So there are two options, or a couple of options. So you can do some work remotely, like in your area. You can collaborate with universities or big cities. Like if you find someone interested in collecting some data, about certain conditions in your area, maybe you can help locally. Or if you want to do short period, like for example here, when they do the residency, they do it in rotations. So they do rotations in bigger hospital when they are in small programs, so they can get good recommendation letters from that hospital or certain specialty. Like when I joined MSU, I had one of my colleague. He was interested in hematology, so he went to, I believe, if I'm not mistaken, went to Cleveland Clinic Hematology Department and worked with them in two projects. And he was able to publish two papers with them. So it was easier for him to go to hematology fellowship and so on. So if you plan to go, for example, to Riyadh or a big hospital, maybe you can connect with them so that you can spend a month or so doing research with big names if they have people who are interested in working in research or in the area of your interest. Or if you want to do certain rotation with them, where you can say, I did my rotation in this big hospital in this area. You don't have to move like permanently there. If I
Yeah,
got
that makes a lot of sense. Yes.
yeah.
But what is it that you guys look for in the CV?
So we want you to number one, communication skills. So this is the basic of your English, and it seems like your English is okay, and the passing the exams and so on. After that, we want when they do the interview for you guys, they already went through your CV, so they look at your clinical experience beside other experiences that you can show them. In the past, you look at publications, how many, and now they look at what type of publication and what impact. Like if you write a paper in a bigger journal with high impact value or factor, it's better than presenting only a poster in a small conference. If you present an abstract in an international conference, it's better than presenting same poster in a local small community hospital, for example. Community service or volunteering, how you are helping your community or internationally, or like some people work with Red Cross. You can do that remotely. You can just answer question. You can educate patients. So you join the Red Cross or Crescent, then you can help in that format. Like your education can help other people in the area. Like in Saudi Arabia, for example, you can ask, see what the government wants to teach the community about any public issue, and you can see if you can help, like address, educate, even if it's a volunteer work in your community. And then any teamwork abilities, leadership skills, teaching skills, innovation, as we mentioned, developing apps and publishing these, working with more than like leaders in the field that you're interested in, big names. All this can help along with your letter of recommendation.
Can I ask more on the clinical experience part? Because here in KSA, it's very much the consultant that touches the patient, like even the specialist or even the residents, they don't, it's not very hands-on, or at least in the city that I'm in, it's not very, so as an intern, it's more like just hands down, like teaching us, not like Sudan. in which like you actually get to hold the patients and etc. So I wanted to ask more on what exactly do you look for in the clinical experience.
So I didn't get that. So when you do, tell me your day, for example, when you go in your internship here
So
at the
so
hospital
here
in the morning,
in
what you do?
yeah, and here in KSA, it's just actually just history taking, and even examination is rare because the residents are a lot, so they don't exactly like it's not very interactive as in Sudan, in which like you actually get to handle the patient directly with your hands as an intern. So like this is why I was thinking maybe like to consider Sudan, but unfortunately like the circumstances don't allow me.
Sure, sure.
So
Yeah, in that case, I think what you can do is you can, I don't know if you can spend more time. This is what I did in my, when I was in Sudan, medical student. In addition to the classes and rotation with our attending, I used to go to Khartoum Hospital cardiology unit in the evening, and I go and see patients and try to figure out how to assess for murmurs, for example, how to examine this and that in actual patients in your own
I
time. So,
Thank
yeah,
you
go
so much
ahead.
for mentioning that, Dr. Nadir. I actually did this in Sudan, but unfortunately, I don't have proof for it. We were very hands-on in Sudan.
Yeah, you don't have to have proof of it. So, what we can, like in your application, what we want you to write is that you are able to take good history, take good examination. You have good report with patients. You have roundings with attendings and case discussion. And if you have meetings, you're attending the meetings or board discussion about
Oh,
cases.
okay then.
Yeah.
Okay. Thank you so much.
Yeah.
Yeah,
Yeah.
thank you so much for this because I was worried because I thought that my effort in Sudan vanished because I wasn't able to get مثلا like a photo or
No, we
because
don't.
the war
Yeah.
just didn't happen. Yeah. Okay.
Yeah.
Thank you so much. Thank you
Uh,
so much.
Welcome. Yeah. Go
Dr.
ahead.
Nabil, I want to just add something for Lujain. Lujain,
Yes.
actually, let me tell you something regarding the working in Middle East and so on, because
Yes.
actually I did my intern in Sudan and so on, but when I came actually I went out from Sudan and so on, and I came to Middle East. I joined first, you can say as clinical attachment, because if you want to start to residency and so on, you have to you should have, you can say, training at least or experience inside the country. So when I joined as a trainee, like as part of my clinical attachment, I noticed the same things as you said, because the first there is a difference in system. Okay, if you look to the Middle East countries, they actually follow health system as electronic health system and so on. So work is mostly of it. You can say based or mostly of task. You're gonna spend your time on documentations and so on. Okay.
Yeah.
You can
Yeah,
say
exactly.
notes or writing even so discharge notes or admission whatsoever. Okay. And in Sudan, actually, we are mainly focusing, you can say, in the clinical practicing and so on. Okay, just
Yes.
like you can say, using the traditional way of management and so on. But my advice, if you want, what actually led me to get benefits from my from the time of my clinical attachment is actually, as Dr. Knight said for you, try even so the director or the chief of resident and so on, try even so to engage. Okay, even so if you took history, or you can say did examination and so on, try even so, for example, in morning meeting to present and so on for doctors, try even so to discuss and so on. Okay, and try even so if you feel you want to practice, why not even so ask for doctors go for the doctor who is gonna be on call within your department and so on. I want to work with you. I want to see like the new patients with you. So that is why I saw the difference. Like, in Middle East, no one will gonna like tell you this task is mandatory for you. It's up to you. If you will gonna like reach out for you can say to learn and so on, and to get benefits and so on, you will gonna reach. But if you like you do not move and so on by yourself, you will gonna like no one will gonna tell you, okay, Lujain, come and take history for this
Yes,
patient.
yes,
Lujain, and do
yes.
examination for
These
this.
are actually like really nice
Yeah.
points. This is why I was thinking of moving to Riyadh because like even here, like can you imagine that the emergency department is actually empty? Like no
Oh,
patients. You were literally just staring at each other.
maybe you
Ye-
can like try move just for the another
Yeah,
hospital.
I think I should move to another hospital. This is why the advice that I was seeking as well, because like I don't
Yeah,
think
yeah,
maybe also the population is small. I don't know, or
yeah.
maybe my hospital is like far away from civilization. So yeah, so this is why I wanted
Yeah,
that advice.
actually,
Yeah,
this is same problem you can say in Sudan, because after you can say war and this like
yeah.
difficult circumstances, not all hospitals same trainings and not highly engaged in patients and so on. So just also if you want to back to Sudan, take this point in consider. Try to
Hmm.
select states there is a highly engaged in patients and so on, and there is a lot of cases will gonna be referred and so on. Okay, so if you feel like also it's very difficult for you like to spend all the 1 year in you can say away from your main estate and so on, you can go just doing like elective, I think it's called, or you can say
Hmm.
clinical attachments and so on. Okay, just like you can say a one rotation or two rotation, that at least will
Hmm.
gonna let you feel confident and so on, and you will gonna feel like you can say taking history and doing examination will gonna be more smooth for you, and you're gonna feel like okay, right now I feel I'm confident and so on.
Yeah. Okay. Okay. Thank you so much for your advice. Thank you so much.
Yeah, thank
Are
you,
you
all the
applying
best.
to this year's match?
Me?
Yes.
No, no.
Oh, okay, not yet. I
Actually,
wish
I'm
you
doing my
luck.
residency here, but
Oh, mashallah.
inshallah, I will. Yeah, but actually, I will.
For
If you
fellowship.
want my advice,
Yes.
yeah, if you want, no, 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 I don't want actually to complete my residency here.
Oh,
But
okay.
yeah, if you want my advice, like try during this intern, complete your exams and so on, prepare well,
Yes.
doing as Dr. Nadir told you, have a good recommendation of letters and so on, letter of recommendations, and even so try building your portfolios. Actually, this is advice I thought for everyone junior. I hope like someone told for me to start from my intern time. So not just you can say focusing on your rotations and so on, your training. No, also focusing on like projects and so on, presentations and so on. And even so that will let you feel at least if the training is not that much 100%, just you can say 70% or 80%, at least you are working at the same time on your portfolios. You are presenting and so on. You are doing projects and so on. So that will gonna help you like inshallah so much.
Thank you so much for this. Like, genuinely, thank you so much, Dr. Nader, Dr. Malaz, and everyone for attending. Like, honestly, this is such a helpful group. And not only that, I'm able to access like people who are also moving on the same pathway because like it can feel very lonely and I'm very confused most of the time as to like what's next, you know? So thank you so much. I hope we stay in touch, Dr. Malaz. I will ask you questions also. So,
Thank you.
yeah, thank you. Wait, I was gonna ask you a question, but I forgot. So, okay, go ahead. Thank you, thank you, thank you so much. Thank you so much.
Thank you.
So in
Oh,
the
wait,
chat,
Dr.
there's
Nader, I wanted to ask a question as well. Is it like for observerships, how like they said you should be able to cold email like professors or doctors? Um, is there any chance that anyone in this meeting today know someone who can, you know, help us reach like observerships? Yes, Dalia said yes, please. Yeah, me too, Dalia. Is anyone aware of any opportunities?
Can you hear me?
Yes, I can.
Okay, so hi, hello, Dr. Nabil. Thank you so much, Dr. Malaz, for your presentation. So about your question, Lujen, I'm actually currently doing a rotation, but it's a tele-rotation. I was not able to apply for the visa. But the doctor with whom I'm working, she's currently taking students, and I could actually like share her contact with you if that's something you're interested
Are
in.
you from Nigeria? I feel like I've heard about her. She is the one who's responsible for the telerotations, right?
I'm not sure I know who you're talking about. Who is that one?
I'm not, I haven't asked for the name yet, but a friend also from Nigeria also had told me about the telerotation as well.
A friend from where?
A friend from Nigeria has told me that there's a doctor as well who's able to give telerotation. Do they consider telerotations like the letter of recommendations for telerotations?
Well, I applied for a visa for
Yeah,
in-person
the States.
to get
Yeah,
it by
yeah.
invitation. And I mean, I know it's not as good as physical. It's always best to be there in person, but if you can't be there, then I guess telerotation is the other option.
Yes. Please, can I contact you as well, like later on or something about this as well, if you don't mind?
Or you can text me.
Okay, okay. Thank you so much. Yeah, wait, I'll just write my WhatsApp number down. Yeah, Dr. Mylene, I sent it on the chat. Yep. Thanks. Thank you, thank you.
Any other ideas or updates or questions?
Yes, Dr. Nader, just I want to tell you like regarding the RCB conference, Royal College, actually submitted the booster and so on, but like they even so emailed us again like I don't know what's the problem, but give us deadline even so for 1 May, I think, to submit the poster again as like they didn't find the poster and we submitted it. Alhamdulillah, يعني. And they emailed us again. Yeah, they received the poster. And Dr. Dana actually tell me, we explain for her and so on and tell her even so anything regarding the project. And right now, actually, she's training on it, okay, in presentation. She told me just if she can present it next Saturday for us, like can we can be as audience for her and we can ask her even some questions and so on.
Yeah, sounds good. Yeah. So
Yeah.
if so they did accept or they did get the poster or they did not get the poster.
Yeah. The first time actually they say no, they didn't get the poster and so on. And just we have to submit before 9 a.m. of 1st of May. Dr. Sindus told her like, okay, I submitted it and so on, and this you can say the number of the poster ID and so on. But I told her, okay, please, can we submit it again because let us to be on the safe zone. We will not lose anything if we submit it again. Why not to submit? Please submit it again and so on. And after submit it again, I think because they did maintenance in system and so on. After the second time, they emailed, okay, right now they received the poster, alhamdulillah, and they will gonna contact her again for this lot of presentation.
Sounds good. So as long as we
Yeah.
are in the right direction, yeah. So yeah, absolutely, she can present to the team here. Next week, you can add her to the update, or if there is slot in the agenda, you can put her name. Sounds good.
Thank you
So
so much.
You're welcome. I want to share with you if there is anyone who is not involved in any research as of yet, or if you are interested and you have some time to work on additional projects. So this is about fibromyalgia. I'm not sure if I talked to you about this before, but basically it's similar to what Dr. Malaz was mentioning about the blood pressure, or Dr. Lujan about COPD. What we want is to look at mobile applications that are targeting patients with fibromyalgia or similar conditions, chronic pain, and so on. So if you are interested, I added the link for this sheet. So you can add your name, your email, and you can pick a role if you want to be the project leader for this project, or a team member, or you want to submit an abstract. So we will have 2 or 3 goals. One goal is to create an abstract and submit it to one of the conferences. If we want to stretch it, we can work similar to what Dr. Malaz did, expand that into a manuscript, submit it to a journal, and or we can also develop an app. So if you go here, you will have some more information. I started collecting some data about available apps, and the team who is interested here, they can do what did like Malaz did, look at what's collected using AI and verify this information, some other data, and a draft about an abstract that we can edit according to what we find in the data. And this is a web-based kind of basic or prototype about an app idea. There are more drafts regarding the app that I'm working on. So if you're interested in doing any part or taking task, there are some tasks that you can work on. So you can just add your names and see if you can start with a WhatsApp group, see if there is one of you can be a leader, just identify some of the tasks, what you want to do, and you can divide the data, verify the data. If all are collected correctly, then you can analyze and see if you want to update, edit the draft, and then see what conferences that can match for similar abstract idea, and you can submit it. This can be submitted to any internal medicine, family medicine, rheumatology group or conferences, IT conferences in medicine. So this can be here in the US or international or in the Gulf area, for example. So, and if you want to update us next week, you can, one of you can let us know how far you are doing. Thank you. Any questions? So the approach will be more or less similar. What I do is I have an idea about one of the disease, and I have the Python program or tool that I use to scrap or to search the two stores, Apple and Google stores, about similar apps, and using keywords, or and then I have the list collected and some of the information from the websites or the database there. then we will just validate this information, and then if everything is clean, then we can go ahead with submitting as abstract first, then we can write a paper, and if everything is okay, we can move on to mobile app development.
Dr. Nader, if you don't mind, do you mind if I took the lead in this project?
I have no problem. Yes.
Okay,
Please
okay,
go
okay.
ahead.
Thank
Yeah.
you so much. Thank you so much.
You're
Thank you.
welcome.
Have a good day. Have a good day, everyone.
Sure. Thank you so much. Bye-bye.
Thank you so much.
You're welcome. Any questions from any of you guys? If no questions, then I'd like to thank you all for attending this program or this meeting. Thank you all the presenters from today. You did great job. Thank you, Dr. Aya and your team. And thank you, everyone. And also, I'd like to thank those who will come and watch the recording in the future. Have a wonderful day and or night, wherever you are. We'll see you next week. If you have questions, please reach me. You can email, text, or call. I'll be happy to answer. I wish you all the best and have a wonderful day or night. Fi amantillah.